Welcome to this therapeutic update entitled The Future of Psoriatic Arthritis. Therapeutic updates are a series of educational videos or monographs dedicated to one topic. For this month, our campaign on PSA All the Way, we've chosen the topic of the future of PSA. It's going to be an exciting series that I'm going to lead off today. We've got a number of really interesting videos that will follow this one, including Laura Coates talking about precision medicine in PSA and Eric Ruderman talking about future therapies in PSA. We have a number of other really exciting videos that will follow, including discovery and new targets, including the future of imaging in PSA, including the prevention of PSA. You'll see these throughout the month featured on Room Now in this therapeutic update. Room Now wants to acknowledge and thank Janssen for its sponsorship of this campaign and this therapeutic update, noting that all the content that is chosen for this campaign and for this therapeutic update was really up to the faculty and the Room Now Advisory Committee. I'm going to begin with a discussion of the future of PSA. Some would say that the future is now. My goodness, do we not have so many better tools, better metrics, better epidemiology, better treatment objectives, better focus on the comorbidities that are killing, and a plethora of new agents that we're just starting to wrap our brains around as far as when and how to best use these differentially targeted therapies. But I would say that maybe drug therapy and new drugs isn't necessarily the answer. This seems to be the case in arthritis, but it certainly isn't the case in dermatology. It wasn't long ago when we started using TNF inhibitors, the dermatologists started soon thereafter. They were using, while we were using 60-40-20 responses in arthritis outcomes, they were using the PsA 75 as their benchmark, and they broke through that ceiling with newer targets. You know, the introduction of 12/23 inhibitors, the introduction of Primulast, the introduction of IL-17 and IL-23 inhibitors, and now JAK inhibitors has changed the game gigantically. They're no longer talking about PsA 75s. They're talking PsA 90, PsA 100. Such is not the case in arthritis. We still seem to have that same ceiling of 60-40-20. It's a steadfast presence in both RA and PsA, which tells us that we have a lot of new therapies, maybe more than they have in PsA. But we're not doing any better, meaning we're not seeing a breakthrough in that 60-40-20 response. So what do we need? First off, we need prevention and cures, but alas, I don't think there's any cure in the recent future for any of us. I would say 2045, and then it's only going to be in a subset of people that will be genomically predicted through certain preventative measures. In the meantime, I think prevention is the way to go, and if that means delaying the disease, so be it. Abrogation by diet seems by far and away the most easiest and the soonest of these interventions. Anti-inflammatory diets will work, but only in a subset. We just don't know who. We know this is true from anecdotal experience, from hints in clinical trials, and really from the evidence that weight loss is very effective in controlling psoriatic arthritis. What's the other big trigger in psoriatic arthritis and psoriasis? It's actually trauma, which could be actually traumatic events and also the kind of work, manual physical labor, that leads to early enthesitis that leads to propagation of pathologic events that become psoriatic arthritis. So maybe genomically defining people at risk where a blue-collar job may not be appropriate. Maybe it means better intervention to better control enthesitis early on, post-trauma, might delay or change the trajectory of disease. I think there's a lot of research that's being done about biologics and even DMARDs that suggests that if you treat psoriasis with biologic and DMARDs, you may be able to prevent psoriatic arthritis using psoriasis as a model of preclinical psoriatic arthritis. But there's a lot of argument on this. While there's a plethora of studies that suggest that the early aggressive interventions can forestall the development of PSA. I think a smarter article done by Alexis Agdi, Joe Marol, and a few others looked at a large retrospective claims database and basically showed that among psoriasis patients, those who got biologics had worse disease and were more likely to get psoriatic arthritis. So we don't truly have the evidence that says that earlier intervention will change the ultimate course of psoriatic arthritis. We certainly do know that severe skin disease becomes a risk factor for the development of psoriatic arthritis. That needs to be manipulated therapeutically. I think more aggressive management of psoriasis, its extracutaneous manifestations, might be the way to go, but that's in the short run. I think what we need to do is make an earlier diagnosis. So if we don't prevent it, how can we make an earlier diagnosis? So I think the problem is we can't rely on current patterns and referrals of psoriasis patients to us who have musculoskeletal symptoms. It's a hodgepodge system. It's heterogeneous. It's slow. It's unpredictable. The wrong patients are getting to us a bit too late. I think what we need to do is take it out of our hands. Let's turn this over to the patients and machine learning and artificial intelligence. I see in the future that psoriasis is going to be diagnosed by Dr. Google. Patients are going to have lesions. They're going to say, I don't know, what is this? What do I have? And they're going to go to some internet-based source, I'll just call it Dr. Google, and they're going to say, hey, Mrs. Smith, based on your search patterns and your buying preferences of OTC meds at Walgreens and Sam's, you have a higher risk of having a chronic inflammatory skin condition, which could be A, B, C, or D. Please go to this site and upload your 360-degree images, and we'll give you a diagnosis and tell you who to go to. So again, patterns, right now Google's doing this with your buying patterns. You know this. This is going to translate into better medicine in the future. Patients are going to be able to upload multiple images, and the image banks right now are getting larger and larger. And the artificial intelligence of them says that they're incredibly accurate. I don't know if you've heard, but dermatologists are not happy with telemedicine. They say you can't do it. It's really horrible. It doesn't work. Well, it breaks up their pattern of business. They deal high volume, short visits. They're hummingbirds. They're in and they're out there. They do pattern recognition. However, the research clearly shows that uploads of images provided by moms worried about kid rashes are like over 90% accurate in making a diagnosis. This gets even better in the future. So the psoriasis diagnosis is going to be made earlier. The interventions, therefore, will be given earlier, provided that they get to a dermatologist. The question is, what about psoriatic arthritis? How's that going to happen? We've already seen research that says that EMRs are going to be equipped with the ability to identify symptom patterns, lab patterns, and treatment use to develop an algorithm that says this person is likely to have a diagnosis of whatever, psoriatic arthritis, ankylosing spondylitis, rheumatoid arthritis, and to refer for specific testing and treatment by the right specialist. So these people who convert from PSO to PsA, it'll happen earlier. It'll happen with greater accuracy. The referral to you is going to be much more of a high yield referral compared to the hodgepodge that you're getting currently. All of this shortens the time from the symptom onset to the initiation of DMARD or disease-altering therapy. There's going to be a number of management changes in the next 5 to 10 years. It's going to begin with clinics. Clinics are going to be redesigned. We learned during COVID that we can all do hybrid medicine. A lot of you don't like it and are going back to the same old way. Many of you do like it. And that's important because that's a part of the future. We can't, as a discipline, meet the population needs for the diagnosis and treatment of psoriatic arthritis and the other 110 forms of arthritis. We're going to need to have wiser systems and remote systems for the management of such patients. So clinics are going to be redesigned to provide care locally, regionally, and highly specialized centers in certain regions for PsA patients. This is going to be for both face-to-face care and telemedicine care. And more importantly, both the clinics and the homes are going to be equipped not with that, fall off the exam table thing that's been around since 1950, but, a workstation that's got 3 or 4 screens for you, the clinician. This is at home. This is at work. And on these screens, you're going to have these second screen inputs where you're going to look at imaging, labs, in treatments and outcomes. And it's all going to be filtered by AI and machine learning to give you better next up decision algorithms where there's going to be an advantage now. Right now, you're flipping the coin on what's going to work next based on the evidence, based on large numbers. The odds are going to go in favor of the patient. They're more likely to have better outcomes with smarter choices of therapy. Technology is going to change, right? We hate technology to a certain point, but technology has changed to benefit the bean counters in the future. It benefits the providers and the patients with an eye toward better outcomes in mind. We're going to have shared patient records that will work like wikis, meaning they're going to be modified, verified, and refined over time, so it'll make for better use in the clinic. Patients will self-manage themselves. They can do upgrades or updates on their care. They're going to be taking digital images of their hands. They're going to be uploaded. They're going to have some traction imaging and radiography to give you volume averaging changes over the hands or over lesions and whatnot. And those are going to be scored, given to the patient, and uploaded to the physician real time. You'll know when the flare happened, when the improvement happened. We're going to have big time use of AI, especially in radiology, where it's not meant to replace radiologists. It's going to improve workflows. It's going to get rid of the mundane, dispel the normals, and create better workflows on things where expertise and integration of multiple forms of information are better. Biomarkers may happen. I don't have a lot of hope for biomarkers. You're all waiting for them. I say wait by the big tree. It ain't going to happen. Prior authorizations are going to get better because basically this current scheme is going to be viewed as illegal and unfortunate for patients, and I think that's going to change. What about other treatment changes going forward? I think combination is going to be commonplace. It's going to be the standard of care in psoriatic arthritis. Anyone who has more than 3 joints, it needs to be on a combination. But we're going to have better combinations, smarter combination. That includes combination biologics, and there's not going to be a higher rate of infection. We need research. Current research is going on in this area. This is not prime time yet. I'm not recommending this right now, but 5-10 years, this is going to be the way. And I'm not talking about a Primolas plus an IL-17 inhibitor or a TNF inhibitor. I think we're going to find that doesn't work very well at all. But in frustration, you're using that and you're looking for a better way. I think we're going to have to put the onus on the manufacturers. You can't get a new drug, a new 23, a new 17, a new, anti-IL-37 approved unless you can provide the differentiator that lets me know using that drug is more than a coin toss. Otherwise, I'm tossing the coin on whether I'm using a TNF inhibitor, methotrexate, leflunomide, abatacept, 12, 23, 23, 17 inhibitors. Again, I am sick and tired of rolling the dice. It's going to get smarter as we go forward. So manufacturers are going to need to invest heavily in developing the biomarkers, the pharmacogenomics, whatever means to get the drug on the market. I think the next great thing is insight from other disciplines. We're going to learn from COVID. COVID vaccination and COVID infection has been associated with worse psoriasis and worse psoriatic arthritis. That's been seen in association with high LL37 levels. LL37 is a defense peptide that comes up, and it is actually thought to be an important mediator of psoriasis skin disease. I think we're going to find LL37 and other microbial targets are going to be important in the future as far as therapy. I think therapies that will target plasmacytoid dendritic cells, because they're the ones that are driving the alpha interferon, the TLRs 9 and 7 that are so important in driving disease and leading to a Th17, IL-17 response downstream. So lessons learned from COVID, and look for LL37 as a target. I think lessons learned from TNF inhibitor-induced psoriasis, the paradoxical reaction. I think if someone spends the time and effort to take that apart to understand how we get to psoriatic arthritis in people who are somewhat predisposed, will lend to better therapy. And lastly, I think IL-36 is part of the IL-1 superfamily, is part of the innate response proteins. Its levels are important in the response that is seen. Interestingly, we've heard reports that JAK inhibitors are highly effective and are going into clinical trials in palmopuscular psoriasis. JAK inhibitors are associated with very, very high IL-36 levels. So trying to mimic that therapeutically will be part of the future. What's not on my list is microbiome. And again, whether this is an autoimmune disorder, the microbiome I think is going to be in play, but mainly to tell us what's the best therapy. I don't think we're going to be manipulating the microbiome. I could be wrong, but I think we're going to manipulate the microbiome to get better drug responses, and that's where the research is going to go. I think we're going to find out that psoriasis and psoriatic arthritis are not autoimmune disease, that they're reactive, that they are in response to infectious triggers, and that what we're really seeing here is a reactive arthritis. Hence, does it not look a lot like reactive arthritis and inflammatory bowel disease and spondylitis? Yeah, it seems to make a whole lot of sense to me. Hope you enjoy this series on the future of psoriatic arthritis.